Well, could you tell me, you were looking here at immunotherapy for lung cancer. You were looking at early stage, fairly early stage, curable lung cancer, cancer cured by resection. What were you trying to do here?
Well, for these patients after lung cancer surgery, the cure rate is about 40%. And 10 years ago, we learned with adjuvant chemotherapy, it could be 45%. And so our current treatment is surgery, often with chemotherapy. But since 10 years ago, nothing happened for these patients. And so MAGE-A3 cancer immunotherapy is a kind of a vaccination against a protein on lung cancer cells, the lung cancer cells that are responsible for the relapse of the patients after surgery. So with this therapy, we wanted to test if we can improve cure rates in these patients.
And there was a good rational basis for believing it could.
Yes, because on the one hand, patients after lung cancer surgery are often weakened. So a mild, gentle therapy as cancer vaccination would be very welcome to them. And on the other hand, we knew from previous data in melanoma that this type of strategy, MAGE-A3 cancer immunotherapy, could induce responses in a difficult to treat disease as metastatic melanoma. And we had signals in early non-small cell lung cancer resected that improved in a smaller phase 2 study with about 200 patients, a randomized study, that it improved cure rates in lung cancer.
Right, now you've been using MAGE-A3 in a phase 3 study, thousands of patients. Can you tell me what was the protocol, what did you do?
In that setting, to validate the hypothesis in a solid way, you need a large number of patients and you need a very well designed, strong study, and that is what we tried to do. So, because the MAGE-A3 protein is present in about 1/3 of lung cancer patients, we had to screen, at the end of the day, about 14,000 patients after lung cancer surgery. And so we looked for the expression of the target, the MAGE-A3 first, and in these patients expressing the target, we then looked for eligibility, and then they were randomly assigned, 2-to-1 randomly assigned. 2 had MAGE-A3 vaccination, and 1 had exactly the same schedule of placebo vaccination. And we randomized a total of 2,300 patients. So by that, it's the largest therapeutic study ever done in lung cancer.
Impressive indeed, and this is against a backdrop of a cure rate which had risen to 45% with adjuvant chemotherapy. What did you find?
Well, unfortunately for investigators and patients, we did not find that the MAGE-A3 cancer immunotherapy improved the outcome results. What did we find? Well, we found that it was a global trial, and in communication with all the disciplines around the globe, surgeons, oncologists, we found that with modern approaches of surgery and adjuvant chemotherapy, so with our standards, that in this very large group of patients globally, the outcome was about 50%. So we made some progress, not by this treatment, but overall we set a new benchmark. But unfortunately, the MAGE-A3 cancer immunotherapy did not met its endpoint.
Okay, so it appears to have no significant signal here. What can we learn about this? Because the use of immunotherapy is attractive, isn't it?
Yes. Well, what we learn is there are 2 types of immunotherapy. There are the antigen-specific strategies, which are cancer vaccinations in the true sense, and there are the immunomodulation strategies with checkpoint inhibitors, which are very much in our focus nowadays. What we learn here is that we tested the strategy of vaccination in probably the appropriate patient group, those with minimal residual disease after surgery, in a very large, methodologically sound trial. What I learned from this is that our current technologies of lung cancer vaccination are not the way forward. We need to be more inventive. We need to find other solutions, because this trial is really a landmark trial, I think, and it gives an answer that our current vaccination strategies in lung cancer do not work.
What is the brief summary message that you would leave cancer clinicians with?
I think we should not leave the field of immunotherapy, and certainly with checkpoint inhibitors, there may be a future for the combination of vaccination and checkpoint inhibitors. So there's a lot ongoing in immunotherapy, but the vaccination strategies as we have them anno 2014 are not the ones that will help us forward.